We are delighted to have participants from Botswana, Malawi, and Namibia. Thank you for joining us today. Let's watch a powerful video about Jacqueline Wende.
Jacqueline Wende, a 27-year-old young woman from a rural place called Masii in Machakos County, Kenya, tells us her sad story of having both hands chopped off, not by thieves, but by her own husband, for failing to conceive, even though he was the one with a fertility problem.
Mandi ndio nilisikia akigonga mlango akiniambia Jackie nifungulie. Niliachana na chakula nilikuwa nakula, nikaamka nikaenda nikamfungulia. Kitambo nimfungulie ndio alikata hii mkono. Nikaanguka hapo chini na akanifuruta nikaenda nikaanguka huko chini. Kitambo nianguka huko chini alikuwa ananikata kichwa na mikono na uso na akanidunga hapa na kisu na hiyo panga alikuwa nayo. Aliponichapa nilimuuliza, kwa nini ngila unanichapa? Utaniua peke yako. Akanyamaza akaniambia, leo ndio siku yako ya kuongea, hautaongea tena maishani.
Merck Foundation came to the aid of Jacqueline through More Than a Mother campaign. She was provided with a new home and a supermarket to enable her to earn a steady income and become independent. Like Jacqueline, there are many other women that suffer from infertility stigma. Merck Foundation works closely with partners to empower them to be heroines of More Than a Mother movement.
Infertility is not just a woman's thing. It takes the two of them to have a child. So many treatments could make it right. So join her. Together yenyar mona da chono bi. Join her. Together yenyar mona da chono bi.
Jacqueline, I want to know that you are my sister. As long as I exist in this world, on earth, my fate is connected to you.
Yes.
So you have to understand this. You come back to me in anything, I will always be there for you, and my room is there. So I'm coming.
Thank you everyone for watching this video. And now I would like to make an important announcement about the Merck Foundation Awards for 2026, and with a focus on the themes that we have, More Than a Mother, and on diabetes and hypertension. So we have our awards on a screen, and I would like to invite our media representatives to write about these awards and encourage young talent in your countries to apply for these awards. Thank you. So total we have 8 awards in 2 categories, More Than a Mother and diabetes and hypertension. So I would request all media representatives from Botswana, Malawi, and Namibia, please invite young talents to apply for these awards. And now we would like to invite you to watch a short promo of our Africa TV program by Merck Foundation.
Senator Dr. Rasha Kelej, and creator of our Africa TV show.
All Africa will be part of our show.
The CEO of Merck Foundation.
We want to support girls' education. No to infertility stigma, yes to girls' education. We want to stop gender-based violence for stop. Number of child marriage will double by 2050.
Thank you for watching this promo, and you can catch this all the 15 episodes on different topics on our social media handles on YouTube. And now we'll start our session. Please welcome Dr. Lugano Dowie from Dowie Medical Practice, and he's also our Merck Foundation alumni from Namibia.
I would like to welcome you all to our session this morning, and I'll be talking on infertility prevention and the link between infertility and infections, and a little bit on male infertility. So the outline of my presentation is to look at infertility prevention and the link between infertility and infectious diseases and male infertility. The key issues here for all the participants is that we want to highlight the need for us to disseminate information to the community as a way of breaking stigma infertility. We believe that the information dissemination is very key in the stigmatization of fertility, and you media players are a key partner in trying to prevent issues around the infertility in our community. Next slide, please. So before I go into details, when we're talking about infertility, basically we're talking about a situation where a couple have been together for more than 12 months and they've been trying to conceive, and unfortunately they've not been able to do so. And there's so many factors that do contribute to that. We group them into male and female contributing factors. But in general, we believe that there are certain issues within our community, within our traditions, within our cultures that we do, some religious practices, in combination with our low socioeconomic status, that we find that are contributing to infertility, especially in women. And most of these things we know that can be prevented. So for example, because of our low socioeconomic status, most of our women are prone to poor nutrition status. And the health-seeking behavior, especially when it comes to issues of sexual transmitted infections, they normally don't go to the hospital or they don't get the treatment required. In some cases, in patients who have been experiencing a miscarriage or termination of pregnancy, and those usually are unsafe and not properly treated, will lead to infection, and that will damage their reproductive system. In the end, that will contribute to issues of infertility. There are certain practices that are happening within our communities. For example, female genital mutilation. So this is part of the touches that are done, but unfortunately, most of them predispose the women to infection. And in general, we've got common things that people can be exposed to, things like smoking or environmental pollutants. These can contribute to infertility in women. And you can see that most of these things are things that we can try and do something about it. So we know that infertility will affect both male and females equally. And in the sub-Saharan Africa, we know that the commonest cause of infection, and that contributes to about 85% of all the women that come to seek infertility treatment. This is compared to worldwide, where the percentage is much lower. So what is our message therefore? Is that we need to encourage our women and our male partners as well to go for regular checkups, because some of these infections are quite what we call silent conditions, where they may not see the problem at the first sight. Only when they come to the doctor and they seek early treatment that they will be able to be treated. So remember, we are trying to give out information for regular checkups for both male and female. One of the commonest infections that we see in women that contribute to infertility is what we call chlamydia and gonorrhea. This is a sexually transmitted, these are sexually transmitted infections. Most of them, they will not have any symptoms. So women will not know when the problem started. However, we know that these have not been treated, then they contribute significantly to problems that later on will arise because of permanent damage to the uterus, where the pregnancy is supposed to be, or from the fallopian tube, where the eggs pass through to get to the uterus. With that, most patients will present with problems of pain, or they may be able to fall pregnant, but that pregnancy will not be in the uterus. So we call it an ectopic pregnancy. However, most of the patients that will come to us because of infertility, when we screen, we do find that they may have chlamydia or gonorrhea. So there is also an association between HIV and infertility. We all know HIV is a sexually transmitted infection mainly, and HIV causes significant changes in the immune system of the body. Besides that, most patients who have significant weight loss and they experience stress, these on their own, they will lead to issues that will affect the conception. But we also know that HIV on its own will affect the hormones that are supposed to help us in terms of formation of the eggs, formation of the semen as well. So in women, patients will present with irregular periods, or they will have no eggs that do come out for them to ovulate properly and conceive. So what are we trying to say therefore? We would want to encourage what we call safe sex, which is to try and prevent the risks that come with sexually transmitted infections, the things I've spoken about, the chlamydia and gonorrhea, including the issues of HIV. So from the media point of view, these are issues where we want to try and encourage one another to try and disseminate information that can help us to reduce the spread of these sexual. So there are a number of things that we can also try and disseminate in terms of information giving out to our potential mothers to try and increase the chances of conceiving. So what are these things? These are issues where we encourage lifestyle modification. So one of them is encouraging patients or mothers to involve themselves in exercise. This we call it moderate exercise, because if you do too much exercise, one, you will lose a lot of weight, and that will also have an impact on weight. So moderate exercise is usually what we encourage mothers to involve in. We would also want to encourage the mothers to eat healthily, and with that, we would maintain a good weight, like I mentioned. We want mothers to have moderate weight, and that helps with ovulation and also the carrying of the pregnancy. Overweight is a problem when it comes to conceiving, and even being underweight is also a problem. So we would want mothers actually to have a well-balanced diet that will maintain. There are general things that we encourage as well that have a significant impact on just health on its own. So quitting smoking, avoiding alcohol, avoiding drugs. Those are things that are also important. And that information we can give out to mothers so that when they avoid these things, at least the chances of conceiving is much higher. We also encourage mothers to limit caffeine. So basically, this also has a direct impact in terms of ovulation, as well as also when it comes to the maintenance of the hormones that are required for one to achieve pregnancy. Again, yeah, exposure to toxins or industrial waste is a risk, especially the pesticides or heavy metals nowadays that we find at times in certain foods, but also in certain environments that we work in, mines and stuff like that. So women are also encouraged to avoid those. But in general, we also want to try and encourage mothers that they shouldn't be too stressed. Stress on its own has got a direct impact in terms of health, hormonal production, and ovulation. So the next part is where we're trying to raise awareness again on the male part. So what is key to understand when it comes to destigmatization of infertility is that men play a crucial role when it comes to reproduction. So there won't be a child if a man is not there. And we also know that men have got the same problems that women do face, that they cannot conceive because of other problems. They contribute to almost 50% of the challenges that couples meet when it comes to conceiving. So it's important that when it comes to infertility and information dissemination, we encourage men to take part. We need to create a culture where we do understand that men and women, when it comes to pregnancy, they all play an equal role, not only women. So therefore, even issues of health-seeking behavior stuff, we want to promote males to take part. So it's always important to encourage men that they join in the journey when it comes to conceiving. Like I mentioned, men are almost affected in the same way like women. 50% of the causes of infertility are in men. So we want, when we're starting the journey, everyone is together. They need to come together and get tested together with their wives or their partners. Infertility on its own is very common between 20, just as like other diseases are much higher in the older. Infertility is one of the problems that this age group is facing at the moment. So what are some of the issues that men do face when it comes to infertility? In a simple way, we need sperms that are being produced. And if there is no production of sperms, unfortunately, they can't be pregnant. And there are a number of things that can affect that. We know that there can be a structural problem where men have got maybe born with an abnormality that will not be able to produce the sperm, or they may have a hormonal problem. For sperms to be produced, they need hormones, and in that, if there is no hormones, then they will fail to produce. The environment, just like we talked about women, things like exposure to drugs, alcohol, exposure to industrial toxins. And what is key in men is excessive temperature exposure, especially to the reproductive part of men. That reduces the number of sperms being produced. Dietary factors and weight loss, the issues that we spoke about in female, are also impacting males in terms of sperm production. Right. So what can we do then to male who are coming to seek for help in terms of infertility? We would want to encourage them, again, just like on the female side, that they limit issues of alcohol intake, drug use, smoking. Again, we spoke about the temperature control. There are certain things that we know that will increase the temperature on the reproductive part of males. Taking severely hot baths, or nowadays we've got, motorbikes that we sit on for a long time and they heat up, then that might have a direct impact on sperm production. So we would want to avoid areas where you get excessive temperature exposure to the reproductive system so that we can increase the sperm production. These are messages that we can try and teach and disseminate to the community. Again, we would like to encourage men to do regular exercises. It's just part of lifestyle modification, and like I mentioned, exposure to toxins or things like pesticides that can have direct impact on sperm production. Okay, well, eating well and maintaining a healthy diet is very key in terms of weight management. It's important that men try as much as possible not to be obese, because that will have direct impact on the hormone that help production of the sperm. So what are the key take-home messages that I'm trying to bring? Number one, so next one, is that infertility shouldn't be looked at as a stigma. As long as people have got enough information, which we as the media and health practitioners are help and provide, that should be able to break down the barriers that we've been facing in terms of infertility. Next slide. Next, yeah. And we know that both male and female can be affected equally in terms of infertility. Therefore, when it comes to information dissemination, we're trying to encourage both male and female to participate in the process of seeking treatment for infertility together, to walk the journey together as part of a group. And that will help to destigmatize the issues of infertility. Next. Yeah, so we need communities to get informed and proper information. That's why Make Foundation, through the More Than a Mother program, provide quite a lot of information when it comes to infertility, and quite a few of us have been trained in terms of information dissemination, treatment of infertility to help out our communities. And we would like to encourage even the media to take part in trying to disseminate the correct information to our communities. And next slide. And men to actually support their wives. We want to see men coming together with their wives in the clinic when it comes to seeking for help with infertility, knowing that both parties play an equal role in terms of infertility. Next slide. And that, yeah, fertility is a shared responsibility. It cannot just be left to the couple alone. We, the media, the healthcare workers, politicians, everyone has got a key role to play in trying to achieve a good community where people are comfortable and able to receive treatment when it comes to infertility, and that people get the correct information. Yeah. And lastly, it takes a man and a woman to have a child. And that's a key information. Yeah, men are more than fathers, women are more than mothers. That's the key point that we want to try. We would really like to encourage men and fathers to take part when it comes to information, dissemination, health-seeking behaviors, and when it comes to infertility, support the women for a healthy pregnancy, but also just in life in general for a healthy community. So for us to break the stigma, there are so many other information that you can get. This slide, we can run it. So there's so many hashtags that we can try and follow on and see what Make Foundation through Make More Than a Mother is doing in our communities and in Africa, mostly in the Saharan region, the impact that it is doing. So there are several hashtags that we'll highlight on the slide that please you can tag along and see. Yeah, so you can just run it through because there's several of those. Yeah. So that marks the end of my presentation. If there are questions, you're more than welcome to ask, and then I can respond. Thank you so much for your attention.
Thank you so much, Dr. Ravi, and thank you very much for the insightful session that we have. He's our doctor, Dr. Godwin Martin Hure. He's from St. Mary's Hospital.
The MC said, I'm Dr. Godwin Martinura from Namibia. I'm going to be presenting on the influence of infertility stigma and other social issues like gender-based violence, child marriage, and female genital mutilation on women and couples, the social and psychological impact. And basically, we are going to be discussing maybe towards the end of the presentation now how media can create community sympathy and also how to write inspiring stories. So Merck Foundation Health Media Training is organized for media representatives, and anyone can actually be a media representative because basically you're just channeling information that is truthful to influence basically the community, their perspective, their knowledge, and all of that. So basically, this presentation is to emphasize the important role that media plays to influence our societies in creating a cultural shift with the aim of breaking infertility stigmas, supporting girl education, women empowerment, ending child marriage, ending female genital mutilation, and stopping gender-based violence at all levels through emphasizing the importance of creating focused and evidence-based content to educate communities for men and women and for empowering girls and boys, also through ensuring that they understand the burden that comes from these social issues, the drivers and the consequences of these physical, social, and psychological issues that are happening in our communities. So basically, these are the things that we are going to go through. The content outline shows what we are going to go through. Okay, so basically we are going to start by discussing the definition, the epidemiology, then the drivers and the consequences of each and all of these issues that I have highlighted on our content outline. So child marriages, this is formal or informal union of a child, girl child, before the age of 18. So this is based on the evidence that was in a paper written by F.F. Bera and Baba in 2020. So globally, the burden of child marriages, there are about 650 million girls or women who are married before their 18th birthday. And a third of these girls are in developing countries and are married before the age of 18. A fifth of these girls are married before the age of 15. And then in Namibia, through the Ministry of Gender and Equality, Poverty, Eradication, and Social Welfare, the prevalence of child marriage among girls in Namibia is around 18.4, and then for the boys is around 4.1%. And the girls' sexual debut is mostly between the ages of 12 to 17, and their earliest sexual debut, which is recorded in these papers as of 2020, was 11 years. And the drivers basically for child marriages, poverty, culture, tradition, early sexual debut, pregnancy, teenage pregnancy, alcohol abuse, and lack of educational opportunities. So these are some of the issues that were highlighted as the drivers that lead people or children or girls and boys to get into these child marriages. So what are the consequences? Basically, these consequences can span from the individual and also be basically up to the national or global stage. Basically, there is a lot of psycho and social pressure that happens as a result of child marriages. And in these child marriages, you tend to find that gender-based violence is also quite common or prevalent within these child marriage situations. And then you find that the individuals involved, there's poor education attainment, and then obviously poor sexual and reproductive health outcomes. Probably you are dealing with a minor who doesn't know better, and most of the time then there's delay of seeking medical help for sexually transmitted infections and all of that. And then just normal sexual abuse is also recorded deprivation of child experiences and abandonment by husbands. So, according to the local statistics in Namibia, these are some of the social, psychosocial issues that the children involved in child marriages actually suffer. Depression and anxiety, post-traumatic stress disorders, and low self-esteem. On a national and a global stage, the roadblock to global health development and gender equality aims are also things that happen. It becomes basically a hindrance to global health and development and gender equality aims through these things. And then according to the Sustainable Development Goals, number 5 target for 2030 to eliminate all harmful practices, including early childhood. So basically, we are pulling ourselves backwards when it comes to when these things are happening. We are not able to attain those goals. So gender-based violence, these are harmful acts that are directed at an individual based on their gender. So it can be sexual, physical, mental, economic harm, threat of violence, coercion and manipulation, intimate partner violence, sexual violence, child marriage, female genital mutilation. So basically, as you can see, a lot of these things are intertwined. So we might look at them now separately, but they are quite intertwined to each other. Globally, the burden for gender-based violence is mainly among the women and the boys, the women and the girls. Women and girls are especially at risk. A third of women experience sexual and physical violence in their lifetime. And then obviously I always go back because the presentation, when I prepared it, it had something to do with local situation in Namibia, where you find that Namibia was ranked 16th in terms of in 2015 out of 145 countries in Africa, as where gender-based violence was quite prevalent. And there's an average of 33% of married women between the ages of 15 and 49 who actually suffer from gender-based violence, and adolescents between the ages of 15 to 19 also. So 6% of women who are between the ages of 15 to 24 experience physical violence during pregnancy, which, as we know, if these kind of things are happening, basically it affects the fertility of the women, it affects the outcome of these pregnancies. So 6% is quite a big number if you look into it. This is of the general population. So the drivers, social, cultural norms, acceptable as a disciplinary measure, like people who say, slapping someone, for whatever infraction that they've done for you, or whatever it is. So socially, sometimes you find in other places this can be acceptable. Poverty, culture, tradition, and also early sexual debut. It's a very, very important aspect to most of these social issues that we are discussing today. But I have particular interest in it because I actually wrote a paper during my MSc Psychiatry a couple of years ago, which was looking at the effects of early sexual debut in relations to depression in later life. And we saw that it was quite significantly important how early sexual debut was actually happening, and then the eventual outcome or mental health of an individual. So it's you find that early sexual debut will keep on popping up as part of the drivers. So then the consequences, obviously, again, the biophysical physical psychological impact is quite immense, because this basically is physical abuse to somebody. So this also undermines all the women's decision-making power, contributes to women and girl poor health outcomes, even increase in maternal mortality as a result of that. Depression, anxiety, And then on a national and global scale, there is always an increased burden because these are things that are preventable, that are actually happening. And then most of these women and or individuals that are affected end up coming into the health system needing long-term care, psychological care, physical care. So the knowledge base of knowing how much burden these things actually have on our communities will help when somebody is really preparing a document to discuss these issues, so that people can actually change in behavior and in an understanding. Female genital mutilation, as all procedures that involve partial or total removal of external female genitals or other injury to the female genital organs for non-medical reasons. And globally, there is over 200 million girls and women who have undergone these procedures. And it's quite prevalent in the Western and Eastern and Northern Eastern regions of Africa, the Middle East, Asia. That is where it is mostly practiced. So affected are the girls between the infancy and 15. That's where you find most of the individuals. Locally in Namibia, this is not something that tends to happen a lot. We do have a small portion of things that happen, not particularly in these age groups, but in the women of childbearing age, where there's a small procedure that is done if a child gets ill, and then they are asked to come to the village, and then they do a few cuts on the private parts, but nothing so extensive as probably what we see in the other regions. And the drivers obviously is social, it's cultural within families and communities. Consequences, they are short and long-term biopsycho social impacts, severe bleeding, problems urinating. Later, they can develop some cysts and infections, complications in childbirth because of the abnormal structure that is now there, and then they will bleed and tear severely. Depression, anxiety as well. And this violates a person's rights to health, security, and physical integrity. The right to be free from torture and cruel, inhuman, or degrading treatment, and the right to life. So on a national and global scale, treatment of health complications as a result of female genital mutilation is estimated to cost a global health system about 1.4 billion US dollars per year. That was as of 2023 WHO. So infertility stigma is very, very important as well. Failure to conceive after 1 year or longer, or 6 months for women who are more than 35 years old of regular unprotected intercourse. This is a definition from the CDC 2023. So stigma, a mark of disgrace associated with a particular circumstance or quality or person. So this is a definition from the Oxford Dictionary. So a sixth of the world suffer from sexual infertility stigma. In the US, 20% of women between the ages of 15 to 49 with no prior births, and 6% for those with one or greater than one prior birth. They also suffer infertility. Namibia, 15% of couples really struggle. That number is quite huge locally, and there is need for investigation also into why it is also that high. Female and males are equally affected. In Africa, primary infertility is up to 49.9%, and secondary infertility is up to 49.7%. So drivers, female genetics, infections, pelvic inflammatory diseases, uterine tube problems, early sexual debuts as well, because they tend to also increase the risk of sexually transmitted infections. And then for males, genetics, oligospermia. So depending on where you are, sometimes these figures vary a little bit. The consequences on individuals and on couples is distress, obviously, because it's stigma. You are being segregated for something sometimes that you do not even have control over, and then obviously financial hardship as a result of a lot of trying all sorts of other things which are also quite expensive to try and get IVFs and all of those other things. Social distress, exclusions, reduced quality of life, and costs for IVF. Just getting 10 cycles in Namibia cost about Namibian dollars 420 or almost 430,000, which is close to $500,000 Namibian dollars, which is quite a lot of money. And then so basically on the national and global scale, this is quite a burden. Okay, so we now go to the role of media basically in these social circumstances. So basically, the world has become a global community where the current space of media is now rooted in technology. Technology has opened up an expansive and far reaching network of communities of the modern day through widespread digital and satellite coverage. So almost everyone has access to a portal to receive information regularly. And radio, television, cell phones, newspapers, mails, emails, access to internet, and the advent of the social media at the moment, it gives us a big advantage actually to be able to spread news that is positive, that actually changes the perspective of communities. So social media has created a global village with its advantages, though there are also disadvantages. So mainstream media is the role of correcting and channeling the truth. The thrill of a good story should not overshadow the truth, which is basically what is happening. So it should also not shadow what is happening, because culturally that is the community you are growing in, and then you have to report as somebody who's impartial, because you are probably affected by the same community and cultures that bind where you are reporting. So authors should question and deduce and highlight comparative issues within and outside communities to improve policies and enlighten the public on relevant social and behavioral problems. So support and inform the communities about the available policies and structures. So it is very important how media interprets or actually educates the communities in regards to these social issues. So writing should be very relatable, should be significant because of the challenges that could be there, should show success stories, should show positive themes, should show psychological, social, cognitive, religious, and economic impacts, focusing on education, educating and exposing, reporting news and current affairs, transforming and celebrating positive stories. And the reporting should be balanced, because we are looking at issues that have probably has got long-standing impact on individuals that are affected, and the reporting has to be balanced, the reporting has to be true, the reporting has to be relatable within the communities. So education should actually come in when we are reporting things about where can somebody actually get the help, what contact details are available for relevant authorities for specific things that the individual is probably suffering from or experiencing. What are the safe areas? Where can someone actually go and seek refuge in situations like this? What are the policies? What does the law say? How can anything be remedied? I know in Namibia there has been a lot of push in terms of gender-based violence into making it very sensitive, that in any circumstance where it is happening, it is reported and then action is taken. So there should be ways that people need to be told what to do. What are the dangers and consequences of being a victim or being the one that is the aggressor? What are the debates in media can organize debates to discuss these relevant things, putting in films and theaters and arts to try and educate individuals. There should be a strong emphasis on mental health care, because a lot of these things, as we have seen, the consequences of it is the psychosocial impact that these social issues have. Okay, so reporting should look into exposing, giving a voice, a platform to express and all these ails. It should be very accurate. Let it be relevant. It should be current. It should be informed. It should be unbiased and with no cover-ups. It should be very independent. So, in conclusion, through these situations, though these situations do appear different, they are quite intertwined together and should be looked at and given the same importance. Not to say one is more than the other, they should be looked at and given the same importance. They are to some extent preventable or avoidable with more education, with more cultural shifts, with more understanding in our communities. These situations create significant trauma inflicted on the individuals involved, primarily the women and children, but also it extends to the other family members and also to the community as well, because you can have an individual who's a breadwinner in the house and basically suffers through gender-based violence, and then the person probably dies or whatever it is, and then obviously the family is going to suffer. So we shouldn't look at it as just as an individual thing that is happening. It does affect more within the community. So this burden is quite significant globally, as we've seen from the statistics. And it is also very important that as media, we actually highlight how much this is, because sometimes perspective that people might be that it's just a minimal thing, just something that is just happening here and there. But if you look at it, you will find that there is quite a lot of individuals going through these circumstances. The social and psychological impact of these ills are significant, and we need to address them from individual to community level or even at a global scale. So media in all forms can be harnessed to positive impact, to positively impact our communities.
Thank you, Dr. Godwin. Thank you so much. So now I would like to invite you all to watch our animation film, Merck Foundation animation film, Sugar Free Jude.
Merck Foundation. No more diabetes. Reverse diabetes. Goodbye diabetes.
It's morning rush time to school, and Jude is about to take a big bite into his breakfast on the go. Jude loves donuts, especially sugar-coated ones.
I love the taste of sugar on my donuts. It makes my morning sweet with this juice combination.
Jude, don't you think your eating habits are too unhealthy? I am worried about the rate at which you consume sugar products.
James, relax. I can't wait to eat my lunch. More donuts? There's nothing to worry about.
Jude was not bothered about James' concern. He went on eating more sweet foods day after day. As the days passed by, Jude started noticing something quite unusual.
My goodness, not again.
Jude would wake up several times at night to wee wee. It was so uncomfortable. Not only that, but he also noticed that he would wake up very thirsty. Jude would need to drink water multiple times during the day as well as night, and this also meant using the washroom several times.
Oh my God, this is so destructive and shameful.
What is it? This appears to be the third time you woke up to use the bathroom. You even look a bit fat. Very unusual.
I have no idea, ma'am. And I've been feeling very thirsty lately as well. And sometimes tired.
We need to see the doctor to make sure all is well with you.
I agree, ma'am. It disrupts my day at school too much.
At the clinic, Dr. Yobo decides to conduct a few tests to confirm his diagnosis about Jude. He opts to do a blood glucose test to check Jude's blood sugar level.
So according to the results, you have type 2 diabetes.
Type 2 what?
Diabetes is a condition wherein the blood sugar level in your body becomes too high. In type 2 diabetes, there is insulin resistance or relative deficiency of insulin that results in excessive blood sugar, which in turn can lead to other health problems. In short, type 2 diabetes is a metabolic condition in which the body's insulin is either ineffective or relatively insufficient to deal with the blood glucose levels.
Dr. Yobo continued to explain to Jude about his condition.
The exact cause of diabetes is not known, but genetics, family history of diabetes, and an unhealthy lifestyle seems to be the most common and important causative factors.
What happens if diabetes is not well controlled?
The long-term complications of diabetes can include the following: stroke, blindness, heart disease, kidney failure, sexual dysfunction, and amputation. Type 2 diabetes is a chronic condition in which there is bodily resistance to the insulin produced by the pancreas, and it typically manifests in adolescents. Managing this will require medication and regular blood sugar tests as well as a healthy lifestyle.
It was tough to accept for Jude at the beginning.
My days with sugar-coated donuts and sweetened drinks are over.
But he had support for his new lifestyle. The school made sure his lunch was not full of the usual sweet things, and his friends reminded him to take his sugar test and play football or basketball with them regularly to keep healthy. His parents were also supportive, preparing healthy meals for him and removing all sweet and sugary drinks from the house. In fact, all family members became sugar-free too. Back in school, Jude and his friends soon formed a Sugar Police Kids Club to raise awareness about the condition and to help others who had diabetes or were pre-diabetic so they can prevent and early diagnose it.
Try to go sugar-free in your meals. Eat more fruits and veggies, along with moderate daily exercise. Our lives can be so sweet without sugar too. Let's all work together to fight diabetes every day.
Merck Foundation. No more diabetes. Reverse diabetes. Goodbye diabetes. We can make it work. 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 Push back diabetes. No more diabetes. Reverse it. We can make it work. We can make it work. We can make it work. We can make it work.
Thank you so much. And this will be more highlighted in our next session by Dr. Billy. Welcome one again. Please welcome Dr. Billy.
Thank you very much, and welcome to this session. I will be presenting on diabetes and hypertension. Actually, this video just almost covered half of my talk, actually. So what is this talk all about? After we have talked about infertility, we are shifting gears. Now we are talking about non-communicable diseases. So our goal today or of this session is to equip you as the media personnel with the knowledge and the ethical framework to report effectively on non-communicable diseases, especially diabetes and hypertension, so that you inspire positive community action. Remember that you are the bridge. Actually, you report, or your reports connect a complex medical information to the public. So Accuracy in reporting is important, and the context also is important. So in this talk, we are going to be preaching the message of prevention mainly. As you know, ladies and gentlemen, treatment as well as rehabilitation come at a very high cost. So the message would be prevention of these diseases is possible and is practical. So let's start with what are non-communicable diseases. First of all, it's easier to give examples. Let me mention cardiovascular diseases. So what are those? Those are diseases like coronary artery diseases. Those are diseases of the blood vessels, the heart and the blood vessels generally, including the blood vessels that supply the heart itself. Those are diseases that cardiovascular disease includes the heart failure as well. Other NCDs, diabetes, cancer, chronic respiratory diseases. So they are basically chronic diseases. They are non-infectious and they are non-transmissible conditions as compared to diseases that you can get from other people like HIV, for example. They result from a combination of genetic, physiological, environmental, and behavioral factors. So sometimes people just throw the term lifestyle diseases. They are the leading cause of death worldwide and represents an emerging global health threat. For those of you who live in Southern Africa, especially South Africa and Botswana, in the early 90s, HIV used to cause so many deaths. But after strategies to prevent and treat HIV, we are now seeing the population of people who have HIV living longer and then end up dying from non-communicable diseases. That is why we are now emphasizing a lot more on these diseases, as well as, or especially, the prevention, so that we don't go to the complications of these conditions. Ladies and gentlemen, these are not just old people diseases, as most people used to believe. They're actually silent and chronic conditions that are now even affecting the working age adults and increasingly the youth. And it comes at a cost, an enormous cost to the healthcare system. You have seen the video of, I think it's a teenager that now has a disease that used to be common in adults. So this is a list of some of the non-communicable diseases: high blood pressure, or you can say hypertension; diabetes, you can say diabetes mellitus; heart diseases, I've given examples of those; heart attack, one of the big killers; and then stroke, one of the disenablers in life. And then you have chronic respiratory diseases, and then you have the cancers. But today, we'll be focusing more on hypertension and diabetes. So with that, I'll start briefly on diabetes. So what is diabetes? It is a chronic metabolic disease characterized by elevated levels of blood sugar, which leads over time to serious damage to the blood vessels, the eyes, the kidneys, and the nerves, right? This condition basically it's like a human being who does not have diabetes is able to manage the blood sugar level. But once you have diabetes, you fail to manage the blood sugar level. And they end up being, or the blood sugar ends up being high. So what are the signs and symptoms that you can get? Excessive thirst, like you feel like you have to drink a lot, or you are thirsty and then you drink a lot. They call it polydipsia in medical language. Excessive thirst, appetite, polyphagia, and you urinate a lot, as you have seen in the video. That guy rushing to the toilet so many times, especially at night. And then you get the weight loss. The weight loss is more common in type 1. I'll talk about the types on my next slide. You've seen the young men there gaining weight because it's type 2. The type 1 tends to lose weight. What basically happens in this disease is that your glucose is high, but because you don't have insulin, or there's a problem with utilization of insulin, then your cells cannot utilize that insulin. So what happens? Your body now goes for the fat and start using the fat. That's why you end up losing some weight. So you may be having a lot of sugar or glucose in your bloodstream, but you are not able to utilize it, right? It's starvation in the midst of plenty. So you also have vision changes. Vision changes is caused by different forms. Usually in adults who have had diabetes for a while, it's damage to the blood vessels at the back of the eye. But sometimes, which is not quite common, you get cataract in the young. Like you see a young child with cataract. It's very rare that one, but it happens. The good thing about it that when it's managed early, they're able to see again. And then you have fatigue. You're always tired. As I've said, you may be having high sugar, but you are not utilizing that sugar. Okay. How will you know that you have diabetes? This is a simplified version of the signs and symptoms of diabetes. As I've mentioned, excessive thirst, slow healing of the wounds, constant hunger, we mentioned it before, excessive tiredness, you're always tired and you're drowsy, tingling, feet and hands, the blood supply to the limbs or the legs and the feet becomes compromised. The nerves become affected. So you will have that tingling sensation on the feet, to the point where you can step on something that is very hot and not able to feel it, or something that is very sharp, not able to feel it, to the extent that you can develop an ulcer or a wound and not able to feel it, but you're able to see it. Or someone tells you, oh, you start smelling that there's something smelly on your feet, only to discover there's a wound there. Then there's sudden weight loss. As I've said, it's more common in type 1 that we'll describe later. And then excessive urination, we have talked about it. If you have a lot of sugar in your bloodstream, you end up losing that sugar through the urine. So usually sugar will go with water. So you'll end up urinating a lot. Blurry vision, I have also talked about it. Now, diabetes. For this talk, let's describe 3 types of diabetes. Type 1, usually the early onset. The early onset meaning it will start at childhood or in the age that you say the youth, around 30 or less. So it's more common in children, type 1. It's the pathophysiology, type 1 and type 2 is different. So type 1 is more like an autoimmune condition in which the pancreas produces little or no insulin. So insulin is a hormone that is needed for your body to utilize the blood sugar. actually drives the blood sugar into your cells. So you can have this high blood sugar in your bloodstream, but you are not able to utilize it when you don't have insulin. So for type 1, you almost don't have that insulin because of this autoimmune system that has destroyed the cells in the pancreas that produce insulin. So amongst the people that have been diagnosed with diabetes in your clinic, almost 5 to 10% of them will have type 1 diabetes. It's not as common as type 2. And then type 2. So we have defined type 2 before. It's a metabolic disorder that involves insulin resistance. You may be having the insulin, but the cells are resistant to that insulin. So now insulin is not able to drive the glucose into the cell. So you are not able to utilize your glucose very well. So this is this condition that it can be prevented or delayed with a healthy lifestyle. Amongst your patients in your clinic or in a population who have diabetes, 90 to 95% of them would have type 2 diabetes. And then you have got a smaller portion of the other types. And then gestational basically means the pathophysiology is different from type 1, type 2 diabetes. This one is caused by pregnancy-related hormonal changes that affect insulin efficiency. And if managed well, and in the majority of people, the blood sugar returns to normal after delivery, but the person remains a risk for type 2 diabetes. So what are the risk factors? Family history of diabetes. Usually it's what we call first generation relative. That will be your parents and your siblings. And then you have got age. Age is a risk factor for many things. You've seen in infertility there that as you grow old, you start having those problems. Age is our risk factor in many conditions. So 45 is the number that you'll see in most guidelines. Then ethnicity, that one will depend on where you are. When you look at South African guidelines, they'll mention certain ethnic groups. When you are in America, they mention certain ethnic groups. And then physical inactivity is our enemy, ladies and gentlemen. You have seen it being mentioned in infertility as well. Too little activity is no good. Being overweight or obese, you have seen also being mentioned in obesity as well. It increases your risk of diabetes and cardiovascular disease, not just diabetes, and cardiovascular diseases as well. Then high blood pressure, this one may be just silent, but your blood pressure may be high. You are still at risk, whether you have symptoms or you don't. Then high cholesterol or lipid problems. And then smoking. Smoking, you will see it in many conditions, including infertility that we just discussed about. So what are you likely to get, or what are the complications that you'll get if you have diabetes? Stroke. Basically the blood vessels of the brain that get blocked. Blindness. I've mentioned the effects on the small vessels of the eye. Heart diseases, I've talked about them. Kidney. The small structures in the kidney get affected and then they start failing. Sexual dysfunction. Actually, this can be one of the signs of complications of diabetes. And then you lose your leg. You lose your leg because the blood vessels become blocked or they become affected such that the blood is compromised on the periphery, on the foot, and then the foot dies, that it will force us to get rid of it, or it becomes gangrenous in our medical term, then it will have to be amputated. And then nutrition. Now we have to talk about a little bit about nutrition. As we have said, prevention is very important. So lifestyle includes diet. So in green there, this is what you should eat often. And then in orange or amber there, this is what you should eat sometimes. And then in red, this is what you should limit. What you should limit, it's basically the most of it concerns the trans fat that is found in margarines, fried chicken, burgers, biscuits, chocolate, ice cream, and the like. So those ones will accumulate in your blood vessels with time and then end up causing cardiovascular diseases. Prevention, healthy body weight. So healthy body weight, usually we'll say, if you are able to check your BMI or calculate your BMI between 18.5 and 24.9, that will be like what is acceptable at healthy body weight. If you can keep it there, be physically active. Whatever little exercise you do will make a difference. But 150 minutes per week will make a big difference to your life, whether you have diabetes or you not yet have diabetes, whether you have pre-diabetes or don't have diabetes at all. Then healthy diet, as we've mentioned. Avoid tobacco use. You will see that in tobacco, we end up saying you have to avoid it. Unlike in alcohol, we say you have to limit it. So hypertension, I'm jumping into hypertension. I'm done with diabetes. Hypertension is diagnosed if or when you have measured at least twice and then your blood pressure is above 140/90. At least twice. You try not to use one reading. You try to use more than one reading. It will be better if it's on different days, then it's more reliable. It's a condition in which the blood vessels persistently have a raised pressure. So it is a leading risk factor for cardiovascular diseases. So the silent killer, why do we keep on saying the silent killer in medical field? Is because it can cause damage, and a lot of damage in different systems while you still don't have the symptoms. So it's important that you get screened, because the only way you are going to know that you have high blood pressure is when you have measured it, okay? So the risk factors, we have the modifiable ones and the non-modifiable ones. So the good thing is that you can have, you can do something about a diet, you can do something about physical activity, about tobacco and alcohol, and weight as well. So as I've mentioned, a reduction in weight of 5 to 10 gives a significant results. Unfortunately, we have the risk factors that we can't do anything about, which is the family history of those particular diseases. And then an age. Now, when you get to more than 65, now the risk suddenly becomes very high. And then if you have other chronic comorbidities, like you have diabetes as well or cardiovascular disease, your risk is very high. The symptoms, very important. If you forget a lot of things that I'm going to say today, remember this one. For majority of people who have hypertension, they will have no symptoms. So they will remain asymptomatic, like no symptoms whatsoever, not even itching anyway. So only if you measure the blood pressure, then you know they have hypertension. That's why we say this disease is difficult to manage, because you start to have to convince someone who doesn't have symptoms that you have hypertension. And then you have to convince them to take the tablet. So it's better to prevent it. So sometimes you do have symptoms. So early in the morning, you may have headaches, nosebleed, irregular heartbeat, vision. So sometimes the blood pressure goes too high, and then it disturbs some of the systems, you may, have those. But I don't want you to rely on these ones and label hypertension as a disease that always have the symptoms. You may not have the symptoms. Severe hypertension can have fatigue, nausea and vomiting, confusion. The moment you have those confusion now is very, very high that you need to go to the hospital. Complications, with the time, the blood vessels get affected. You can see the wall there of a normal vessel and then a damaged blood vessel. Inside there, the lumen is very, very small. That puts you at a risk of developing the strokes there. This is the blockage of the small vessels in the brain. The heart attack, one of the big killers, it's a blood vessel that provides the heart itself with the blood, is blocked. And then the kidney, the blood vessels there, they're very narrow. And then they get blocked. These are some of the complications of hypertension. So prevention, please, this one is the message you are trying to spread. This is from WHO, reduce salt to less than 5 grams per day. 5 grams is more like a teaspoon, not so full, not too heaped, but a teaspoon. Eat fruits and vegetables regularly. Avoid saturated fat. I've talked about it. Tobacco and alcohol. So you'll see in tobacco, we say avoid. And then in alcohol, you can limit. And then be physically active every day. That's how you'll be able to prevent hypertension. Let's move on. Control. High blood pressure. You can control it. Now we are talking about someone who has unfortunately now ended up having hypertension. So the first message is diagnosis is not a death sentence, okay? So when you have high blood pressure, now you have to control to prevent complications, because the complications, they are very costly. But if you have high blood pressure without the complications, it's much better, okay? So follow medical advice, very important, and lifestyle. Lifestyle is always there in all NCDs. Take medicine as prescribed, regular checkup of blood pressure, and reduce or manage stress. You have seen it being mentioned, stress being mentioned in fertility as well. So to the media, my last 2 slides, to the media, please remember that you provide an important link between the community and the health sector or the health information. You also expand our audience. You know we can't reach to all people, but you may be able to reach to more people than we do. So we want you to spread this message of prevention. So by focusing on practical and lifestyle changes, demystifying screening as well, and telling stories of empowerment, your report can be directly motivating to the community and the community to take more proactive steps for their health. My last slide. The media can be used at many levels of audience. As I've said, you have access to more people than we are as the health sector. So health promotion, disease prevention, it's very important. So our goal is to enhance a state of well-being to guard health and population at risk. Remember, ladies and gentlemen, my last parting word is that you are not just reporting on health. You are actively contributing to the public health ecosystem of our community. So you should report responsibly to inspire change. Thank you, ladies and gentlemen.
Thank you, Dr. Billy. Thank you so much. That was a very interesting session on diabetes and hypertension. And now we have a media speaker, And lastly, we have Mr. Moses Kofa. He's an executive director of the Media Council of Malawi.
Thank you very much. Welcome, my colleagues from Malawi, from Botswana, from Namibia. I think today is a good day, a good start actually of the year 2026, when we are discussing very important matters pertaining to the lives of the people that we serve. For us to give them information, for them to adequately use that information, they need to be healthy. So I think today it starts that kind of process. I will be talking about the role of the media, focusing very much on our role in disseminating information or sharing information with the grassroots communities. I wanted us to, first of all, I think from using the Q&A section or the chat section, you can also comment because this could be more interactive. If we can share why we think rural communities are often at the last to receive last serving information. Most of the times when we're looking at this kind of information, we adequately discuss it on these modern platforms. We have access to all these meetings with stakeholders in urban areas, but taking the information down to people in rural communities becomes a challenge. Much as we know, we have community radios out there, but even reporters in the rural communities find it difficult to access information in time. We have the national media outlets, which also have representation in rural communities. But even for them, it takes time for them to access information that can be disseminated, shared with people at grassroots in good time. And apparently, someone joked at some point on a certain forum that the problems, the health problems that we're discussing today for urban people, for rich people, no, you wouldn't hear someone in the rural communities, in the village, saying I have diabetes, saying I have high blood pressure, and so on and so forth. It's because we don't discuss these kinds of issues adequately with people in the rural communities. So let us share what we feel is the reason why we are still having this problem, failing to discuss these critical issues with people in the communities. Secondly, we need to understand that the media should go beyond reporting news. It's not always about this person said this at this particular function, but let us go deeper into investigating critical issues affecting the people in the rural communities. Why is this happening? What information do people need for them to make right decisions? So we are advocates, we are educators. This is also one most important thing that we need to bear in mind as we continue with our conversation today. Next slide. So the objective of our conversation today is basically to see if we can we can improve our storytelling, moving from just telling the stories to changing behaviors. How far do we go? How far are we going to make sure that people begin to understand the challenges, the issues affecting them in their communities? Social investigations, social research. What techniques, what tools, what skills do we have that would help us ask those deep questions that would help to expose or to bring out the real issues affecting people in the communities. So we need to, first of all, understand that radio is king. This time, we know that a lot of people in the communities believe in what radios publish. And they have more access to radios than TVs and other platforms. So as media practitioners using community radios or using our representation in the rural communities, we need to make sure that there is continued dominance of the voice of the people from rural communities. Let us hear the challenges, what is really affecting them, what is hindering their process, the decision-making process that would help them actually improve their livelihoods, improve their lives, and improve their communities. We also believe and we know that this time we have gone digital. A lot of people now are accessing information through the digital platforms, and most of them look at the credibility of the information they access on social media platforms if it is linked to a credible media outlet. So any kind of information that we come across, any kind of information that these people come across, they would cross-check with our credible, our platforms. They want to see if this particular radio published this particular information so that they can verify the truth about that particular information. So let us also see how we can align the social media platforms, the WhatsApp and all those kinds of platforms with our media outlet. And then there is the issue of interactive programming. We need to provide spaces for people to share their views, to give you their understanding, their level of understanding of these particular aspects, these issues that we're discussing, so that now you are able to understand the gaps, the information gaps existing in the communities. At that level, that's when you can that's where you can engage the specialists, the stakeholders who will ably respond. A journalist is not a health specialist. A journalist is not a politician. A journalist is not an accountant. A journalist is there to process information for the audience, for the people to make right decisions. So we have to make our programming more interactive. And then the issue of language also matters. When we are talking about issues affecting people in the communities, let us also bear in mind the kind of language that these people speak, so that we are able to speak in their language. We are able to simplify the terminologies, the scientific terminologies, the scientific technical information that people need to understand for them to make decisions. So our regular consultation with specialists in the communities is very paramount. And we also need to engage our experts in the rural communities, even at national level, to be able to interpret or to simplify the technical jargon that is normally used when they are serving people. I've always listened or heard people complaining about the handwriting of doctors. I don't know if it's everywhere, but right here in Malawi, I think it's common knowledge that people complain they're not able to read or to understand what the handwriting of doctors. Is it everywhere? Now, this also relates to the language that doctors speak, the language that specialists speak. Most of the times they use words that people cannot understand. So let's work together with media practitioners to make sure that we are together simplifying the terminologies, simplifying the language for them to understand, to relate with their daily lives and be able to make decisions. Next slide. I would like to briefly talk about these particular issues. There is issue number one, which is talking about the infertility stigma. My colleagues who have presented before me have shared quite a lot about these issues. So infertility is not a curse, and it's not a women problem. I heard, is it Dr. Godwin, if not Dr. Bonisi, who mentioned at some point that you cannot talk about infertility without talking of a man and a woman. So wherever we are discussing about infertility, wherever we are talking about the challenge of stigma with regards to infertility, it should not only affect one person. It should not only affect a woman. It's a problem for both a man and a woman. So what should the media do? We should begin now to think of normalizing infertility as a medical condition affecting both male and female. If we continue expounding or actually emphasizing on the usual language that is shared in the communities, the blame game, blaming women for not giving birth or conceiving and so on and so forth. I mean, it has always been there. I have first-hand information, first-hand evidence of people who have left their wives, even to go look for other women, sleep with other women, to give them male children because they have given them their wife is giving birth to female children only, and they go out there to look for another woman who can give them a son. Similarly, there are a lot of men who have left their wives in search of a child. I mean, we need to begin to have a conversation around this as a problem that is shared between a man and a woman. And then we also need to make sure that in dealing with these issues, let us focus on solutions. And the solutions should involve the male counterparts. It's not only females. What are men doing to deal with these particular issues? So that in the end, we bring everyone on board to make collective decisions in dealing with the problems that are affecting us. And also providing information on accessible reproductive health services. When we are dealing with these kinds of issues that affect the psychological aspect of human life, I mean, we need to also look at who is providing these particular services. Let us provide directions to the people that we are serving, to the rightful service providers, be it counseling services, be it reproductive health services, and so on. Issue number 2 is on girl education. When you're talking of girl education, we are talking about this because we do not want to always be reactive. We want to be proactive. Let us discuss these issues proactively before something bad happens. We need to begin to educate our young girls, our young men, while at that age where they have not yet started making these kinds of decisions. And one thing that we need to do is to change the focus. We have always encouraged girls to go to be in school by focusing on the benefits of education. But at the same time, we know that when a girl child goes to school, they are going there at the age where they could have been more sexually active, to find themselves making wrong decisions because there is nothing that's keeping them busy. So we are sending them to school to keep them busy, but that is not the only reason. While education has got a lot of benefits, we also know that this is the time when we can highlight the other issues or the other factors affecting their life. When they drop out of school, they'll find themselves getting married early. They find themselves falling pregnant early, and these have got negative effects on their health. They have negative effects on their finances, on their economic status, and so on. I think we need to begin now to expand our focus by not only just discussing the mere stuff of the benefits of education, but let us discuss the other aspects that would actually come into play when they have made a wrong decision of going for marriage, early marriage, or early pregnancies because they have dropped out of school. The other thing is about now the how we profile our stories. Who are we involving in our stories? How many people? Because when we are talking about when we want to use community radios, we also know that even the producers of these particular programs in community radios belong to the same community. You are able to identify people who have done better, people who have made right decisions, better decisions in their communities, who can be role models to young girls who might prey to unnecessary or irresponsible sexual behaviors. So the way we profile our storytelling techniques, our approaches also matters in dealing with these particular issues. Then the policy awareness. What are we advocating for? What protective laws are existing for our students, for our young girls, for our young boys? What grants or what programs are there in the communities which would actually support or help our young boys and girls to remain in school and to receive the necessary support that they need as they progress in their lives. The third issue that I would like to talk about is the issue of now child marriage and female genital mutilation. I know even my colleague Dr. Godwin also mentioned that in our region this is not mostly common. The FGM is not mostly common, but it's common probably in the East and West Africa. But still, we have to talk about it because most of the times these are issues that are discussed in secret camps where initiations take place, and so sometimes we might not be aware of the actual stuff that happens in those particular secret camps. So we need to make sure that we are sensitive to the language that we use when we are dealing with these particular issues of child marriage. Sometimes when you go to a specific community, you'll notice that it's normal for them. Sometimes they even protect one another. If you want to discuss with traditional leaders, with people in rural communities about child marriage, they will not respond to you comfortably because to them it's normal. It's their culture to send their children early to get married because they want to benefit in them. So we need to also be very sensitive with the way we use our words by not condemning, by not blaming, but trying to change the behavior, focusing on the benefits of education, focusing on the challenges that come with early marriages or child marriages and the female genital mutilation. We also need to make sure that we understand the legal realities. Let us understand the laws that are applied in these particular instances. All these, the international instruments that promote education or that promote the fight against child marriage and against female genital mutilation. But in that regard, we also have the Media Code of Ethics and Professional Conduct, which guides how we report on harmful traditional practices without alienating the traditional leaders and the people in our communities. Let us understand the laws guiding marriage, the laws guiding divorce, and the laws guiding the regulation of the institution of marriage in our respective areas or in our respective countries. And this is also aligned to the statutes in our respective churches, the religious institutions that we belong to. So we need to understand all these kinds of aspects because they interlink and they work together. So if you don't play safe, you find yourself creating enmity. Eventually, people will not accept to speak with you. They will not accept to have their voices on your radio because of the way you have used your language, the way you have failed to interpret the laws, and the way you have created that kind of tension in the community. Let us also try to identify some community champions in the same areas. There are lots of health service providers in our communities. We have a lot of political actors, the counselors, the health specialists in our communities, and other educators, the teachers, the religious leaders, and all that. Let us identify these kinds of community champions, because when people hear an advisory from someone they know that they live with in the same community, they will easily listen to that person and follow whatever they are teaching them to do. And then the issue of gender-based violence. Let us now, like I've said earlier on, let us move from the blame game. Let us move from labeling other people as instigators of specific behaviors, but let us focus on solutions. So our reporting should now be survivor-centered. Let us not kind of expand or emphasize on the behaviors that led to the incidences that we are trying to advocate against. When you're talking of gender-based violence, we focus on not a victim, but a survivor. We talk about these people who have gone through, have experienced gender-based violence as survivors, not victims. When you just talk of someone as a victim, already the perception is negative. But let us focus on them as being survivors. What did they go through? We are trying to avoid putting them at risk of further violence or stigma. We are trying to protect them, and we are trying to help the community accept them in their respective communities, in their respective families, and so on. I've first-hand evidence of people who have been raped, people who have been sexually harassed, and they have had nowhere to complain to. Eventually, they're just locking themselves in the house because they are ashamed to go out to interact with their own families, to interact with people in their own communities, and eventually they lose their lives. So if we want to promote behavior change, let us focus on the survivor-centered reporting by fighting or engaging the survivors to explain more their experiences and how these kinds of situations can be avoided. Then we talk about the mandate of each media practitioner or each media outlet to make sure that whenever we are writing stories about gender-based violence, we should also include helpline channels. Where can people get more support, counseling, or psychosocial support, as we call it? let us guide them to direct them to these particular service providers so that in the end they are helped, because it's not always it's not always about being accepted in the community, but trying to actually also deal with long-term effects of the incidences that happen to the survivors. So even when you have you have not yet experienced the gender-based violence, the harassment and whatever, but you are sensing that this the way this particular person is behaving, this is where probably you are going, and this is what might happen. You already have to be proactive in reaching out to service providers who can protect you and who can help you. And then there is the secondary victimization trap. The way we use pictures, the way we describe the scenarios, what happened to the survivors that we are featuring in our stories also matters. So we need to be very careful to avoid publishing details that can shame the survivors and details that can easily identify the survivors, because what we want is to protect them. So how do we break the barriers through interactive media? I mentioned about interactive media at some point. And one of the things that we need is to encourage funding programs, allowing grassroots voices to ask experts questions in real time, use arts, radio dramas, so that we can just create stories out of what we have heard from the survivors. So we create stories and then feature them without actually aligning them to any of the survivors in our communities, but talking about the real issues affecting the people in the communities. And then we also have citizen journalism, where we also train local participants, local youth to report on social issues in their own villages. We are talking about these days, we are talking very much about social media influencers. Can we find social media influencers in our communities? These are citizen journalists who can always bring issues out when they happen. When we train them, we also encourage ethical conversations in the communities that we serve. Next slide. We have the ethical guardrails for grassroots reporting. We talk about information consent. You cannot just publish any kind of information before seeking consent from the people that are involved in our stories. So we need to ensure that our rural sources truly understand where their story will be published, how it is going to be used. Any kind of information we're getting from them, they need to know how it is going to be used before we can publish it, so that they give us their consent. Then respect for tradition. I mentioned about this at some point. We need to engage our local structures before embedding spaces of sources for an investigative kind of story. And then we also need to avoid reporting based on other Western styles. We need to make sure that our reporting is very accurate, reporting Malawian issues for Malawians. We need to report in a way that a Malawian is going to understand us. We need to report in the same way that Malawians tell their stories, so that at the end we are with them and we promote their lives as part of their lives. Next slide. How do we measure success? We need to always be good researchers. As a media practitioner, our job is not only to gather information and write about it. And like I said also, it's not about the hard news style. This, who did what happened, where did it happen, and so on. But we also need to measure the impact and the reaction and the actions that are taking place after our publication of the story. So we need to be good researchers, monitor what people are doing after going through our programming, after reading our stories, after interacting with us through our our platforms. So the knowledge needs to be assessed. The attitudes, the changes in the practices and all that needs to be assessed so that we are able to measure the impact of our programming, the impact of our stories. Let us create all those avenues, all those platforms that can help us track feedback. If we are writing a story and we have put kind of a measure of the impact of that particular story, we also need to check around if are people really behaving the way we expected. Are people really conducting themselves in the way we expected? That is one thing that we also need to pay attention to. So we need to be very good monitors, very good researchers, on top of being good writers. And then the issue of sustainability, we need to ensure that awareness does not stop when NGOs or institutions that are supporting us in the communities stop giving us the support. Most of the stories that we write in communities when it comes to social issues are supported by NGOs that are existing in those particular areas. And eventually, even the writing, the stories that we write, the angles that we take are actually dictated by the organizations that are funding us. That is why most of the times we find that the problems that we have been dealing with 20 years ago still exist today because someone is directing us, directing what we have to publish and what we should not publish. It's not always about successes. We also need to be agile in discussing the challenges facing other solutions that are being promoted in the communities. How are people adapting? How are people adopting the solutions that are being advocated in the particular communities? What challenges are they facing in implementing those particular solutions? So sustainability depends very much on dealing with those particular issues, those particular challenges that people are facing, and they want to implement solutions that we are advocating through our platforms. So in conclusion, I want to call on my fellow media practitioners to be partners in development wherever we are working with our rural communities, our rural experts. Let us be partners in development, not just spectators or not just reporters. We need to be there to understand why problems are existing in communities, what solutions are being promoted, and what challenges are people facing in implementing those particular solutions. When the moment we begin to participate in dealing with these particular challenges, we will help our communities. And then the last thing is to make sure now that we do our work in compliance with the Media Code of Ethics and Professional Conduct to ensure that our reach out is safe, respectful, and impactful. Thank you very much.
Thank you, Mr. Moses. I would like to thank all our speakers, participants for the engagement today. Thank you, everyone. Thank you so much.